The study in question is a phase 2 study. It was conducted at multiple sites throughout the US and in Europe. And the goal of the study was to evaluate a novel drug, Belzutifan, and look to see how effective it was in patients with VHL. Why Belzutifan? So Belzutifan targets hypoxia-inducible factor 2, which we know from years of research appears to play a critical role in causing these tumors in VHL patients. Both the VHL gene and the hypoxia-inducible factor pathway are also involved in the more common sporadic form of clear cell kidney cancer. But as part of this study, we are primarily interested in looking at the efficacy of this agent in patients with VHL-associated tumors. Until recently, we didn't have drugs that could directly target HIF2. And so when this class of agents started becoming available, we are very, very interested in looking to see if they would be useful clinically in patients with VHL. And that was the reason behind embarking on the study. I've already told you why it would be nice to have alternatives to surgery in managing these patients. And here we have a drug that we think targets a very key part of the pathway that leads to these tumors. So we designed this phase 2 study and included patients who had at least one measurable renal tumor and a tumor that didn't need immediate surgical intervention because we didn't want to let patients have a large tumor sit there and go on an experimental therapy when the right thing to do would be to take them out and start minimizing the risk of metastatic spread. Patients should not have been previously treated with systemic therapy directed at VHL-associated tumors. So these were some fairly simple, entry criteria. We of course needed to have a confirmed diagnosis of VHL, which we did by evaluating their germline and making sure they had a germline VHL alteration. The primary goal of the study was to evaluate the activity of single-agent Belzutifan. The overall response rate in kidney tumors was what we were primarily interested in looking at. And this was evaluated by an independent review committee. But I told you that these patients also have tumors in other organs. So in an organ-based fashion, we also looked at responses in individual organs. So in addition to responses in the kidney, we also looked at responses in the pancreas and responses in CNS tumors, as well as in the eyes. We also were interested in looking at other parameters that told us how durable these responses were, duration of response. We also were interested in time to response and other clinical efficacy parameters. Last but not the least, very, very interested in looking to see how safe and well tolerated this drug was in this group of patients. Patients with VHL, although they undergo multiple surgeries during their lifetimes, in between these surgeries, most of them try to lead as normal a life as possible. And so if you gave them a drug that caused them a lot of side effects or affected their quality of life, it was unlikely to be accepted broadly by VHL patients. So it's very important to really understand how well this drug was tolerated by these patients. So we enrolled a total of 61 patients, and the data were reported last year in the New England Journal of Medicine, and an update was also presented at ASCO this year. The update at ESMO 2022 was a 36-month follow-up. The median follow-up was actually a little over that, 37.8 months. And we looked to see how the efficacy and safety parameters looked with this longer follow-up. Not surprisingly, but it was very gratifying to see that the response rates remained high. In fact, it was higher than we had previously reported. In kidney tumors, the overall response rate had climbed up to 64%. This included 7% of patients who had complete responses in their renal tumors. We also saw in the 50 patients who had CNS hemangioblastomas an overall response rate of 44%. And in the 22 patients with the pancreatic neuroendocrine tumors, the overall response rate was 91%, including 7 patients, approximately a third of the patients, who had complete responses. We also had 12 patients who had retinal hemangioblastomas. Some of them had both eyes affected, so there were a total of 16 eyes that were affected by retinal hemangioblastomas. And we saw improvements in all 16 eyes in response to treatment. So it's very good to see that the responses we previously reported holding up. In fact, the response rates are going up. We also wanted to see how durable these responses were. At the time of this analysis, 34 of the 39 patients remained on drug and remained in response. So if you had a response, the majority of those patients had continued to maintain a response. Of the 61 patients, 38 remained on study at the time of this analysis. The most common reason patients went off study was because they chose to go off study. So 11 of the 23 patients who actually went off study at this time chose to go off study. And this could be for a variety of reasons. Some of them may not have liked the side effects, even though the protocol didn't mandate that they go off study. They wanted a break and said, I'm going to go off study for a bit. In August of 2021, Belzutifan was approved by the FDA for treating this very group of patients based on the study. And so some patients elected to try and get this drug as a standard of care option rather than remain on the study. Whatever the reasons, 11 of the patients went off study of their own volition. There was progression seen in some patients. So 6 of the patients had progression in their renal tumors and had to be taken off study for that reason. A few other things we looked at. So we've looked at efficacy, high response rates. The responses seem to be durable. What about safety? I told you it was very, very important. And the safety signals that we had identified in previous versions of this trial, previous analysis of this trial data, held up on this analysis as well. There were no new safety signals. Anemia continued to be one of the most common side effects. It was a predictable side effect of this drug because this drug also targets pathways that are very important in erythropoiesis. So we were not surprised. We actually look at this as a way of determining indirectly that the target is being hit adequately by this drug. Patients also get fatigue and a host of other symptoms. Most of these symptoms were mild, meaning they were grades 1 and 2, with some patients, around 15 to 16% of the patients, exhibiting grade 3 adverse events that we could attribute to the drug. So overall, very well tolerated, nothing new in terms of safety. We were also interested in looking to see if reducing the pace of growth of these tumors, or actually reducing the size of tumors, had an impact on the way we manage these patients. I told you until now the patients with VHL are largely managed surgically. So we also wanted to look to see if patients were needing less surgery than they did before they went on the drug. And indeed, that seems to be the case at this point. The follow-up is relatively short. But if you took all the 61 patients and looked to see in the 4 years before they went on the study, how many surgical procedures did they need, and try to compare them with surgical procedures they needed after starting the drug, we saw a distinct difference. In the 4 years preceding study entry, 46 patients needed at least one procedure, and a total of 87 procedures was performed in these patients. In the follow-up period to date, only 9 patients required surgery, and a total of 11 surgical procedures are performed in these patients. So with this follow-up, at least, it seems as if we may be making an impact on the surgical burden that these patients have to endure. So the hope is, one of the hopes is with a drug of this kind, we can delay or in some patients completely obviate the need for surgical intervention. And how effective we are in achieving that goal, I think, remains to be seen. So that sort of summarizes what we saw at this extended follow-up with this extended follow-up analysis.